Conduction abnormalities intraventrically. So the intraventricular blocks, such as the bundle branch blocks. Intraventricular blocks or bundle branch blocks, if any of the bundle branch is blocked, the ventricles get depolarized indirectly through the muscle. Because the depolarization taking place through the muscle, this is why the QRS complex is wide. So generally talking, when the width of the QRS is equal or higher than 0.12 second, meaning 3 millimeters, we are talking about bundle branch blocks. The cause is mostly ischemia or myocardial infarction. The type of the blocks can be which based on that bundle that is missing. Right bundle branch block, left bundle branch block, and the left bundle branch block composed of two fascicles, two branches of fascicles, such as the anterior hemiblock and the posterior hemiblock can occur when the anterior fascicles or the posterior fascicles is missing. Bifascicular block is when we do have a right bundle branch block that associated with a part or a portion of the left bundle branch block, such as the anterior or posterior hemiblock. Trifascicular block, when we do have a right bundle branch block, plus we do have a hemiblock, plus a AV conduction abnormality, so we do have a first degree of AV block. Very similarly, ischemia, myocardial infarction causes these blocks. The conducting system is very sensitive to ischemia. This is why ischemia plays a very huge importance in the development of these bundle branches. Let's look at how normally the ventricle depolarized. First, the septum is activated. The septum gets impulse from the left bundle. This is why the first depolarization wave, the septal depolarization wave, comes toward the right side, toward the V1. After we do, so we do record a positive deflection in V1 and a negative deflection on the left side in V6. Next, we do have the left and the right ventricle activation together. That's pointing from right to the left. This is why in V1 we do have a deep S wave, and in V6 we do have a tall R wave. When everything is activated, relatively, we're going back to the isoelectric line. So normally in V1 we do have RS complex, and in V6 we do have a QR complex. Now, to determine how long does it take to activate the muscle that underlies the electrode, this is what we are introducing, this ID time or intrinsic deflection. As long as the muscle is not activated under the electrode, it's more positive comparing to the depolarized area. So when the charge comes, we always detecting positivity. However, when we activate this area, that's be negative, and the other area be positive. So every charge goes away from this point. So from the beginning of the QRS till the last R wave, that can give us this intrinsic deflection or ventricle activation time. These are synonym words. What will happen when the right bundle is missing? So when we do have a right bundle branch block, well, the septal activation is still normal. So because the septum gets the impulse from the left bundle about 90%. Now, V1 we have this initial R, in V6 we do have an initial Q wave. Next, the left ventricle activation is still normal because the left bundle is not altered. So we do have a S wave in V1 and the R wave in V6. The right side of the ventricle can be activated from the left ventricle, and because it's a slow one, bigger impulse generated by pole made by this activation. This is why in V1 we do have a tall R and wide tall R waves, and in V6 we do have a deep round S wave. So if we are looking at the ID time, the ID time is elongated in V1 and not altered in V6. When you're looking at the surroundings, in V2, you can see that this is the M complex or RSR complex can be detected. And in V5, V6, very similarly QRS complex where the S wave is wide. Right bundle branch block, when we do have this block, the septum and the left ventricle depolarization is normal. The right ventricle is activated from the left ventricle through the muscle. The activation of the right ventricle is slower. This is why the ID time or ventricle activation time is longer in V1 or in V2. The shape of the V1 and V2 is wide, the QRS shape is wide and nudged. ECG features wide QRS wider than 0.1 seconds, M complex or nudged R wave in V1, wide slurred S wave in lead number 1, AVL, V5, V6. These are left ventricular leads. Secondary depolarization abnormalities can be seen because when the depolarization altered, the repolarization is be altered as well. So this is why it's be inverted. ST depression and inverted T can be detected. The second part of the QRS complex is abnormal. The first one is correct. However, the second one be abnormal. Looking at this graph, we do have rhythmic heartbeats. The rate is around 75, 80, for example. P wave is present, so the sinus rhythm PR is normal. QRS is wide, all right, and axis is around 30 degrees or so. When we do have a wide QRS, when we're suspicious about bundle branch blocks, you should look at V1 and V6. If V1 we do have a wide R wave or the ID time is elongated, that's the right side, so right bundle branch block. If we do see in V6 a wide R wave, that should be the left bundle branch block. But here you can see only a wide uh, S wave, slurred S wave on the left side. Incomplete right bundle branch block. Incomplete means that the width of the QRS is less than 0.12. However, the old shape of the QRS is typical for the right bundle branch block. ST depression and T changes can occur as well. What is the importance of this incomplete block? A lot of cases, for example, in acute pulmonary embolization, coronary disease, atrial septal defect, right ventricular diastolic overload, myocarditis can be behind of this incomplete right bundle branch block. But don't forget, it can be a normal variant as well. When we have the left bundle branch block, the septal activation is abnormal as well. So the septum can be activated from the right side. This is why in V1, because that's parallel, doesn't happen anything. In V6, then we do have a rise of the R wave. And because the septum is part of the left ventricle, these depolarizations of the left and the right ventricle goes on from right to the left. And this is why we do have a deepening of the S wave, a little increased by this loop, but we do have the end that can cause a notching of the QRS complex in the S wave in V1 and the R wave in V6. And when it's finished, everything back to the isoelectric line. So if you're looking at the ID time is 0, so it's normal in V1 where we have this QS complex, and on the left side, that's be along because the second R is the important, clinically importance. The surrounding one, as you see here in V1, the R, initial R is missing, but in V2 it can be seen. And this M complex can be seen in V5 as well. Left bundle branch block, summarizing this all. Activation of the septum as a left ventricle is abnormal. The whole QRS is altered. The left ventricle is activated from the right ventricle through the muscle. ECG, wide QRS, nudged R wave on the left side. Lack of Q, initial Q in V5, V6. RS or QS, however, in V1 and V4. The prolonged ID time on the left side, such as in V6, proving that that's a left bundle branch block. And for sure, always we're having a secondary repolarization problem. Looking at this tracing, rhythmic heart rate about 75, P wave, yes, we do have P wave, QRS, PR interval is normal, QRS is wide. Looking at V1, that's a QS complex. V6, we do have a wide R wave. Similarly, in lead number 1, we do have a nudged R. So that represents a bundle branch block in this case. The axis, as you see here, this is about it's a left deviation because 1 is positive, AVF negative, and lead number 2 a little bit positive. Because the left bundle branch composed of fascicles, branches of fascicles that runs on the anterior wall or runs on the posterior wall. The depolarization of vector goes upward and to the left when we do have an anterior hemiblock. ECG features 1, AVL and QR leads 3 AVF, the RS. Main electrical axis is ranging in the pathological extreme left deviation from -30 to -90. The QRS is normal. So the hemiblock is not going to elongate the QRS complex to the pathologic range. Here you see for rhythmicity, except here, because that's a premature beat that breaks this rhythmic heartbeat. Rate is around 1, 2, 3, 4, 5, 6. It's about 60. Let's see, the axis, 1 positive, AVF negative, left deviation, 2 negative, pathological left deviation. AVR is negative, meaning that the axis is located between -30 and -90. When we have left posterior hemiblock, in this case, the posterior fascicles doesn't work. Left ventricle is activated from the anterior fascicle. ECG features that 1 AVL RS leads to 3 AVF QR. Mean electrical axis ranging 100 to 180. The QRS is less than 0.12 seconds. Rhythmic, heart rate is around 100. Sinus waves, okay, QRS is narrow, except you do see here RS are complex in V1 and possibly in V6 as a, so already have a hemiblock, that is a left posterior hemiblock due to the pathological right deviation. In this ECG tracing, we can see a typical sign of right bundle branch block, as you see here in V1, an RSR complex and a slur deep S wave on the left side in V6, V5. Plus, if you look at the axis, the electrical axis, 1 positive, 2 negative, meaning that's a pathological left deviated. AVR about equiphasic, so that's about -60. So together we do have right bundle branch block plus an anterior hemiblock, and that's called bifascicular block. It has a name, an author's name, that's a Lenegre syndrome, because the same coronary supplies the right bundle and an anterior part of the left bundle. We can have bifascicular block with right bundle branch block together with the posterior hemiblock. Here, as you see here, typical RSR complex in V1, and the axis should be deviated to the right. We can have trifascicular block, the most common one when we do have right bundle branch block and left anterior hemiblock. So a bifascicular block together with the first degree of AV block. In this case, the conduction blocks in all three fascicles that can be permanent or transient, and other criteria beside of this left anterior and first degree AV block, that's a right bundle together with the left posterior plus first degree AV block, or then we do have a left bundle branch block together with the first degree AV block, or if the patient does have an alternating right bundle branch block with left bundle branch block. In this picture, we can see the typical sign of right bundle branch block. The axis pathologically deviated to the left, so left anterior hemiblock, and if you're looking at the PR interval, it's elongated very well. So this is why it's a trifascicular block. In the next, we do see the left bundle branch block picture together with a increased AV conduction. So that's a trifascicular block. As in other conduction, these bundle branch blocks can be different severity. It can be second degree, can be third degree. When it's third degree, all the time we do have the typical pattern of right bundle branch block or left bundle branch block. However, if it's only the second degree, meaning that sometimes the right bundle conducting or the left bundle conducting normally, but sometimes they do not. Usually this comes when the rate increases, and when the rate increases, the bundle doesn't have enough time to repolarize. This is why the typical right bundle branch picture comes in every bit. As you see here in the upper panel, when the patient had a rate of 80, only a few picture or few complex shows the right bundle branch block pictures. However, when the rate increased to 150, the all QRS complex is white, and the all QRS complex shows the typical pattern of right bundle branch block.